Everyone, tonight it's another pediatrics series and the third in our pediatric one. And first I just want to acknowledge the Ghana people on which we meet and where we work at the Children's Hospital, and their leaders past, present and emerging. So our first speaker is Dr. Jovanka King, who is a paediatric immunopathologist, our only one in South Australia, in fact one of the few paediatric immunopathologists full stop, and who did her higher degree at the Karolinska Institute, and we're really pleased to welcome her back into the discipline of paediatrics this year as one of our clinical academics. Over to you, Jovanka.
Thanks very much, Jenny. I'll just share my screen. And hopefully everybody can see my slides there. Yep, great. So thanks very much for the introduction and for the invitation to present today on some of our work. So just to summarise paediatric immunology research at my various institutions, this encompasses vaccinology and allergic diseases, and I think you heard from Helen Marshall and Michael Gold, my colleague, recently in those domains. And today I'm just going to give a bit of a snapshot into some of our work on inborn errors of immunity. In terms of background, immunodeficiency diseases can broadly be classified as either secondary due to a variety of different conditions or primary. And these we refer to as inborn errors of immunity, and these are genetically determined conditions. They're highly heterogeneous with a variable clinical phenotype. And although they do commonly present in young children, they can have onset or delayed diagnosis at any age. The hallmarks of immunodeficiency disorders are recurrent, unusual or severe infections, with some pictures here to demonstrate some of these manifestations. And these patients are also at an increased risk of malignancy, immune dysregulation or autoimmunity. So we're dealing with over 450 different monogenic disorders which are associated with inborn errors of immunity, and this number continues to increase over time. And broadly, we classify these according to the predominant immunological defect. And today we'll focus some of our discussion around combined immunodeficiencies, which affect both T and B cells, and predominantly antibody deficiencies. So our work, both in the clinical domain and in our research endeavours, really gives a nod to the fact that early diagnosis and treatment improves patient outcomes in inborn errors of immunity. And we address this through increasing awareness in the public and amongst clinician colleagues, and by having research lines which address improved diagnostics in terms of immunodiagnostics and immunogenomics, and also addressing newborn screening for these conditions. So I'll focus the discussion on newborn screening programs. So these date back to the 1960s, where Robert Guthrie developed a screening test for phenylketonuria. And the collection method hasn't really changed much since this time, where all newborns have a heel prick blood test collected and blotted onto this filter paper known as a Guthrie card. And this is then tested for a variety of different diseases. Not all countries or all locations will screen for all diseases, and this is a bit variable depending on lots of factors, including local prevalence. So the aim of newborn screening programs are to identify severe life-threatening diseases in neonates in the asymptomatic period, and where early intervention in terms of medical treatment improves clinical outcomes. And you may have heard of the Wilson and Jungner principles and these criteria which are actually applied to selection of candidate diseases for screening programs. Severe combined immunodeficiency, or SCID, is one such condition which was proposed to be added to newborn screening programs. This is a disease which occurs due to a mutation in a gene that's associated with T cell development or function, and is manifested by absent or reduced T cells. These babies typically will present in the first few months of life catastrophically unwell, and this represents an immunological emergency which is uniformly fatal without definitive therapy with either a bone marrow transplant or gene therapy. And evidence has shown that if bone marrow transplant is successfully conducted by 3.5 months of age, that outcomes are much better for affected babies. And really the only realistic way that we can achieve this is to screen these babies at birth for SCID. So how do we go about this? Well, we measure something called TREC, which are T cell reception excision circles. So these are small circular episomal pieces of DNA which are formed during naive T cell development, and these can be measured using a simple qPCR methodology. And similarly, there is a B cell counterpart called CREC, which are markers for naive B cell development. And we would expect in a baby with SCID that they would have low TREC levels and sometimes low CREC levels as well. And low CRECs are also seen in congenital B cell deficiency disorders. So my group in Sweden were involved in this largest prospective study, which evaluated a TREC-CREC screening program. And the data that was obtained from this actually provided the foundation for the newborn screening program in Sweden, which continues to the current day. So currently around the world, there are many countries who are screening for SCID using a TREC or TREC-CREC approach. And we are hopefully due for national implementation in Australia in the very near future. This figure here over on the left shows how we can look at the pattern of TRECs and CRECs to help us to identify different patients with inborn errors of immunity. And interestingly, some of these techniques and assays that we use for diagnosis in newborn screening, we can also apply to patients who we are working up for an inborn error of immunity. With this work here showing that CREC levels in patients with X-linked agammaglobulinemia, or XLA, a congenital B cell deficiency, remain low throughout life, meaning that this assay could be useful at other stages beyond the newborn period. So this screening process will identify inborn errors of immunity manifested by T and or B cell lymphopenia. But what about these patients here, the coloured bubbles here, who have other forms of IEI but have normal T and B cells? And this led us to pursue a couple of different options. So our first approach was to look at developing a test for newborn screening for hypogammaglobulinemia. Low immunoglobulin levels are a feature of primary antibody deficiency disorders, but can also be seen in other inborn errors of immunity. And typically we would measure immunoglobulins using protein measurement techniques such as nephelometry or turbidimetry. However, in neonates, the immunoglobulin levels that we measure are confounded by maternal immunoglobulin levels. So you can see here that maternal IgG is transferred across the placenta in the 3rd trimester. And this work here by one of my colleagues demonstrated that maternal IgA is in fact detectable in the neonatal circulation, suggesting that we need a different approach to identify hypogammaglobulinemia in newborns. So we went a step back from protein and we looked at the expression of the immunoglobulin heavy chain genes to determine whether this was decreased in patients who are unlikely to be producing their own immunoglobulins. So from dried blood spot specimens from newborns, we extracted RNA and then performed a qPCR assay to assess for the immunoglobulin heavy chain expression for a variety of different immunoglobulin isotypes. Here on the left, you see with a normal healthy control infant that there is good level of expression of these different genes compared to a patient with XLA who has absent expression. And we managed to demonstrate this in a number of different patients with this condition, showing absent gene expression compared here to normal healthy control levels in healthy neonates. And this thus demonstrated a proof of concept for this approach. So we have then gone on to apply this to our current study where we're actually evaluating gene expression in older patients who have immunodeficiency conditions. And so far we've shown some variable expression of immunoglobulin genes according to the level of hypogammaglobulinemia and other features observed. And this has various applications and we're hoping to develop this into a new diagnostic test, and this work is supported by the National Blood Authority. So what about the future? So it's not really feasible for us to try to screen infants for a variety of different conditions using different methodology. And it's thus been proposed that a potential new approach might be upfront next generation sequencing using either whole exome or whole genome sequencing. And this would enable us to simultaneously interrogate hundreds of disease-associated genes. And we have argued in this paper here that all forms of IEI are clinically relevant, and there are things that can be done to manage these patients, and early identification is key. Obviously, this is a big proposal, and there are lots of considerations as given here in terms of considerations, including testing characteristics themselves, how we'll manage variants of unknown significance, and importantly, ethical, legal, and social implications. So in the future, in South Australia, we have a project that's due to commence later this year where we're actually going to evaluate a multi-omics approach to newborn screening in an attempt to improve newborn screening for a variety of different conditions, including inborn errors of immunity. Unfortunately, can't go into too many details at the moment on this due to embargo, but hopefully we'll have an update on this perhaps next year. So I might skip over this in the interest of time. So thank you very much for your attention, and I'm happy to take any questions.
Thanks very much, Jovanka. It's very interesting. I mean, it's this, there's an integration omics which is occurring even more beyond genomics alone. It's really exploding. Even in my area of type 1 diabetes, which is yet to have a preventive measure, there are pilots beginning literally the second half of this year, including here in Adelaide. So it's a really expanding area. Really,
yes, it certainly is.
area.
Yeah. Yeah, and I think a lot of this, the future genomic approach, I guess so far we've focused really on monogenic conditions, but yeah, I think that we'll be looking down the track at, disease susceptibility factors, I guess similar to your population, and also potentially polygenic disease, which so far is, is not as well understood.
With its interest, but unknown effect on the anxieties of the population when you haven't got immediate interventions. Yeah, that's really interesting. Thank you very much. I learned a lot. I found it very interesting in relation to our work as well. Now I'm just looking at the chat box here. I can't see anything in Q&A. So I just, well, as Cara has mentioned, there's an opportunity to look at these separately and ask later questions. So many thanks, Jovanka.
Thanks,
I'll
Jenny.
just wait a sec in case there's any questions coming through from the participants, but no, I don't think so. Our next speaker is Dr. Anna Kontos, who is a postdoctoral scientist and is really under the leadership of Declan Kennedy and Kurt Lushington for a long time now. Anna driven the sleep program, which is really more from vascular work, initially cognitive work to vascular work, and has been a great, fascinating area.
Thanks, Jenny.
For some time.
10 years now, just clocked up 10 years.
So, and I know how much Anna's driven this program, so great to hear from you.
Thank you. Okay, so I'm representing the Paediatric Sleep Disorder Research Group, which is based at the Robinson Research Institute. And as Jenny said, Professor Kennedy is our theme leader. My contact details are there if you would like to contact me about any further information about my research or our research. So we primarily investigate sleep disorder breathing in childhood and how that affects the cardiovascular, autonomic and endocrine systems, neurocognitive and behavioural differences, microbiome, dental facial evaluation and neuromuscular evaluation. And a secondary investigation, which would commence more recently, is looking at SDB in maternal health and birth outcomes. So I'll just centre this one on our this discussion on our primary investigation and what we've found so far. So for those who don't know, sleep disorder breathing, or SDB, is quite common. If your child snores more than 3 times a week, then it would be considered to be on the SDB spectrum. So when we go to sleep, we lose some muscle tone that's included in the airway, and so the airway tissues become a little bit floppy. And so as air passes through it, in some people where it's excessive, you get vibration and snoring, and partial or total collapse of the airway, resulting in snoring, apnea, hypopnea, arousals, intermittent hypoxia and hypercapnia. So SDB has prevalent studies have suggested that around 10% of children have the disorder, and that the disorder emerges in prevalence at 2 to 8 years. It's a spectrum of disorder ranging from primary snoring to obstructive sleep apnea, with those with obstructive sleep apnea having more apnea and hypopnea events throughout the night. Primarily, it's diagnosed through an ear, nose and throat specialist, through parental report and an airway assessment of the tonsil size and the adenoid tissue size and impedance to airflow. However, the gold standard is an actual sleep study, so polysonography done in a paediatric sleep lab to determine the obstructive apnea hypopnea index. Treatment is adenotonsillectomy. However, many children, as many as 40%, continue to snore after treatment. Our group was one of the first to show neurocognitive and behavioural issues with SDB, and were pioneers in getting more investigation in this area for children and their families. So the reason, so our work has now stemmed more into vascular, looking at the vascular effect of sleep disordered breathing in children, because we know in adults sleep apnea is independently associated with systemic hypertension, and increases a person's risk of an early onset cardiovascular event like heart attack and stroke. So the data from the adults is suggesting that people with sleep disordered breathing who are not diagnosed and not treated are more likely to develop what they call early vascular aging. So what's early vascular aging? You'll see just up here, there's a graph. So normal people, as we age, if we age normally, we'll start to become a little bit hypertensive in our late 50s and early 60s. However, in about 20% of the Australian population, people start to get hypertensive in their mid to late 30s. It's why this group of people develop early hypertension that is important to our research, because what we think is that because so many of the 10% of children that have sleep disordered breathing, only about 20% get treated in childhood, and the majority go off to potentially become adults with sleep disordered breathing. And what we think is in the early stages, they start to develop this change in vascular profile, which looks like, so this is a young vessel and this is an older vessel, and you get smooth muscle hyperplasia here in the medial layer. You get fibrosis in the intima, you get damage on the endothelium, and the vessels get stiffer and thicker. And so a lot of my research has worked on trying to first determine if they have stiffness using functional tests, and then if they've got increased hypertrophy and hyperplasia of the smooth muscle from structural evidence. So here is some of the evidence from our group and other groups that sort of support our work. So we were one of the first to show increased blood flow velocity in the brachial artery at rest in children with mild sleep disordered breathing, and these children were aged 5 to 9 years old. The Hill group also showed in even younger children, aged 3 to 4, increase in cerebral artery blood flow velocity of, again, around 20%. And then in a subsequent study using cardiac MRI, we showed an increase in the ascending aorta blood flow velocity, again, of around 20%. We've also showed in young children aged 5 to 9 a delay in reaching maximal dilation using flow-mediated dilatation. And again, these children were fairly mild. And using a similar ultrasound device in the metacarpals, the Gazelle group showed a delay in reaching maximal dilation in the metacarpal vessels. In older children, there's a group in Hong Kong and one in Italy that have shown reduced dilation response at 60 seconds, which is the standard traditional measure taken in flow-mediated dilatation. And more evidence, there's been multiple studies around the world looking at blood pressure, and a common feature is increased diastolic pressure and a reduction in nocturnal dipping. We've also recently shown increased platelet aggregation, which is an indicator of vascular injury, and it's consistent with findings by the Gazelle group that showed soluble CD40 ligand, which is a platelet marker, to be increased in children with sleep disordered breathing. There's a myriad of markers in inflammation or cytokines that have been shown to be increased in children with SDB in all varying levels, so from primary snoring all the way up to obstructive sleep apnea. And they're consistent with ones that we see in cardiovascular disease. So what's most concerning are the 3 longitudinal studies, that the results from those that have come out recently, where children who have tested in childhood using the sleep lab technique for obstructive apnea hypopnea index. So at all severity levels, these 3 different studies showed that when tested using FMD, that they all had reduced dilation response and reduced vascular distensibility at follow-up, suggesting that untreated SDB in childhood may be an independent risk factor for hypertension as well. So what do we think? How do we think that these changes arise? So you have with sleep disorder breathing, the sleep fragmentation, the intermittent hypercapnia, hypoxia, and that even just the drag itself activates pathways within the brain that activate the sympathetic nervous system, and in particular the nerves that can control blood flow along the arteries and the vessels. And what we think, because the disorder happens every night for many, many years before they're diagnosed or they're treated, this, especially during development, remodels the peripheral vasculature first, and then that causes the vessels to become stiffer, and then it also then over many years changes the way the heart develops as well, and then you get the vascular repair and hypertension in later life. So here is the pathway of mechanisms that we are investigating, particularly now, so looking for structural evidence. So this is some work that was done by Professor Bill Blessing's lab many years ago, and I worked in that lab for a little while. So this is a rabbit, and on the artery in the ear, they've put a Doppler flow measuring blood flow, and they've also put one on the femoral artery. And this is a rat, and the same Doppler on the tail and one on the mesenteric. And so when you get a stimulus, so the animal is at rest, you get a stimulus and you see this massive vasoconstriction in the ear and in the tail, but very minor vasoconstriction and reduction in blood flow in the larger vessels. And this reduction in flow occurs because you activate the sympathetic nerve, the postganglionic sympathetic nerve terminals, which release noradrenaline and constrict the smooth muscle cells that are in the media. Sorry, that's me touching the thing. And over time, what we think is the noradrenaline, as well as activating this vasoconstriction in the smooth muscle cells, it also works on the fibroblasts in the adventitia, turning them into myofibroblasts and recruiting them back into the smooth muscle layer, into the media. They also make extracellular matrix proteins, especially collagens 1 to 3, and it compacts this adventitial layer and also compacts the outer layers of the blood vessel. So what and that we think is why you get this delayed dilatation response in our children that we've reported. So we wanted to have a look if we could measure these fibers in a blood vessel, and as I mentioned, don't worry about that slide. As I mentioned, the the treatment for sleep disordered breathing is adenotonsillectomy. So we collect the tonsil tissue from children in our study, and the largest collateral in the tonsil is the dorsal lingual artery. So these are images of the dorsal lingual artery from 2 different children. One has a high blood flow velocity value, one has a lower one. The green fibers are stained to tyrosine hydroxylase, a marker for sympathetic nerves, and the red is the smooth muscle actin, which is the smooth muscle cells. And we have a custom-made software that has been developed with one of our researchers to then determine the sympathetic nerve fiber density. And so then we looked at the relationship between the density and our vascular measures. And so we saw a really strong correlation between the sympathetic nerve fibers and our blood flow velocity measurements at rest, and also the time it took to maximal dilation. Now, we also use pupil-like reflex just before the children go to sleep in the sleep study and when they wake up. And what we found was a inverse correlation between the sympathetic nerve fibers and indices of the light reflex. And so the light reflex is governed by the parasympathetic, so slow constriction and a larger diameter of the pupil is indicative of higher sympathetic activity. So that's quite a consistent correlation. And again, I mentioned we did platelet aggregation. We showed that that was increased in children, and we were able to show that the children with higher platelet aggregation values had more of these sympathetic nerve fibres. So then we sort of thought, okay, well, if the theory is right, then we should be getting this hyperplasia in the smooth muscle cells and hypertrophy. And so we looked in the dorsal lingual artery of the other tonsil, and we managed to get 36 cross sections of that. And you'll see the top one here is one that's got thicker medial thickness, and this is a thinner one. And this child here is, I think, about 7 or 8 years old, and this one is about 12. And so we looked at that in relation to the blood flow velocity, and again, we've got some nice, strong, good correlations between the medial thickness and the velocity time integral values, and the peak systolic ones as well, and also with smooth muscle numbers, and smooth muscle layers. So there is a relationship between blood flow velocity at baseline or at resting and this hyperplasia. And as I mentioned, in adults, it's SDB is an independent risk factor for systemic hypertension. So in other words, all the blood vessels in the body are changing. And so this is consistent with what we think is happening in adults, but it's happening in children. So we do other research as well. We've done some microbiome work, looking at changes and shifts in microbiome, where I'm not going to go through all of this stuff that we've done, but we've noticed that there's less variability in the microbiome in patients with sleep disordered breathing compared to controls. And what we think happens is because they have their mouth open, it changes the niche. It's very similar to what it is when they're awake, as opposed to when people have been sleeping with their mouth closed for most of the night. That causes dramatic changes to the different microbiome populations. We've also done some really interesting stuff with David Wilson, where we've looked at, used the dorsal lingual artery for arterial myography. So this is one of the first that's ever been done. And so we can actually use this artery to manipulate it to look at constriction and dilation, and then stain it afterwards so that we can look at these fibre and the fibre density and how that relates to this profile of constriction. We've done some work in dentistry with Dr. Ben Lee Yap, looking at changes in the dental facial morphology, and what we've been able to show is that children with sleep disordered breathing have a much higher palate and have a lot more crowding with teeth, suggestive of sort of jaw issues. We've also, when they take the tonsils out, there's always some residual muscle, and we've started to look at that differences in the muscle. And what we have seen is kids with worse sleep disordered breathing have thicker or wider interstitial spaces between the bundles of the muscle, and that the muscle bundles are more irregular in shape. We've done some inflammatory profiling as well. I won't go into that today because I don't think I've got very much time left. And then we've been doing some maternal work as well, looking at placental tissue and cords in patients with mothers with sleep disordered breathing. So we've got a lot of capacity because we've got multiple collaborations around the university, and not just our university, but also the University of South Australia and at Flinders. So I won't go through all those, but our main things, obviously, polysonography in children, and vascular measurement, and tissue work. And we also have neurocognitive and behavioural testing. And what we need, because I think that was one of the things that was specified, we'd love to work with a cardiologist that could help us sort of work out the next step with the vascular stuff and the vascular assessment. Certainly an endocrinologist, because we have one of our PhDs is working on the endocrine profile in children with sleep disordered breathing, and the results that we've gotten so far are very interesting. And given the stuff with the jaw and the muscle, we really would love to look more closely at the genetics, and so the genetic underpinnings of the disorder, and the muscle expert to give us more information on that. Epidemiologists now, one of the things I forgot to mention, 1 in 2 children who are overweight or obese are thought to be on the SDB spectrum, and most of those children, when treated, do not normalize, so they don't stop being on the spectrum. So given that we've had a massive increase in children's body mass, it would be very interesting to know that effect, the long-term effect. And then, of course, a post-treatment study to see if that's enough to change the course, and to develop a model, an animal model of the disorder, and track the vascular changes, or where we might be able to make substantial difference to vascular health. And that's all of us, the collaborators, and that's Declan there, James, who's recently retired, and Kurt, and David Wabnitz, who works with us through the ENT department. That's it. Am I on time?
Yeah, thanks, Anna. It's amazing having known about this program when it began and how you've expanded. And I imagine the stuff on the tonsillar histology is pretty unique internationally. Is anybody else?
No, that was
your idea.
No one. That was my idea. I kept saying to Declan, we need to get vessels. Where can we get vessels? And it's like, I don't know. And I said, I think the tonsils. And it's remarkable, because when you actually look under the microscope and see it for the first time, because I know the children, obviously, because I take them through the whole process. So I know their VTIs and everything. And I obviously give that data to our students to then determine the values for the medial thickness. And they don't even know what they're doing. So when they come back with the data and they've got these beautiful correlations, I just sit there and just go, you know, this can't be this simple. But you know, you can pick it when you look at them, because they are so different. And we have been, last year we had a student who worked on, because they take some of the gland as well, so the pharyngeal glands that are there, and the differences across children, and how that relates to the muscle and the vasculature. So you sort of see like a pattern of children, so that have a much thicker collagen infiltration, especially in the muscle and the vessel, and a much different profile in the gland. So it is a systemic thing. It's occurring everywhere. It's not just in the airway, and it's concerning, because it's a lot of these kids get diagnosed with ADHD and a whole heap of other things before they actually get diagnosed with sleep disordered breathing. So it can be sort of, the kids, you know, 2 or 3 had problems, and they've not been diagnosed until they're 12 or 13, because they've gone from, you know, one child psychologist and this and that, until they're properly diagnosed, if ever.
Yeah, that's really, it's really interesting. It's a really big area of sleep. Really exploded over the last 3 years. So it's a fascinating combination today. Thank you to both our speakers, Jovanka and Anna. And as Cara said, these can be watched according to the details given by the Minireview organisation group. Thank you.
Thank you.